Everyone. My name is Peter Su. I'm from the University of Technology, Sydney. And today is my great pleasure to chair this section and welcome everyone to the CVRN November seminar session. And for both the in-person attendees and the online attendees. So I would like to starting with acknowledging the country, the traditional owners and custodians of the land on which we are standing today. The lands of the Gadigal people of the Euro Nation. I would also like to acknowledge the lands on which our online attendees are joining from today. We pay our respect to all the elders past, present, and emerging. And before I introduce our first speaker, I would like to give a quick introduction to the CVRN, the Cardiovascular Research Network. So the CVRN was established in 2005 to strengthen, facilitate, and promote cardiovascular research in New South Wales through collaboration. And we do this by developing and supporting the strategic events and opportunities to enhance research capability with particular focus on the early and mid-career researchers. And currently, all the major research institutes and universities are member organizations of the CVRN, and this includes all the New South Wales local health districts. The CVRN has over 600, as you can see here, over 600 members across research spectrums from basic to public health researchers investigating all aspects in cardiovascular disease, including diabetic, stroke, and kidney disease. And the CVRN is funded by the New South Wales Health and the organization membership fees and supported by the Heart Foundation. And we have an executive committee that drives the strategic direction and a rising star subcommittee responsible for developing and driving the events and opportunities for EMCRs like this seminar sections series. And this committee is co-chaired by Dr. Jessica Orchard, Dr. Alice Gibson, and Professor Jimmy Vanderberg. So today, this is our Rising Star subcommittee when we had an online meeting. And today, our seminar will be focusing on the topic of innovation in cardiometabolic health, dietary patterns, clinical decisions, and population insights. So we will have an amazing lineup of 5 speakers, 4 EMCRs, and 1 PhD student. As far as I know, everyone from yesterday was EMCRs because we have our amazing speakers who just got her PhD grades. And so each of the EMCR speakers will speak for 10 minutes and the PhD student will speak for 3 minutes. And after that, after each talk will be a Q&A sections. So you are welcome to ask questions by raising up your hands or post on the Zoom chat box. Our next speaker is Dr. Tian Wang. So she's a research fellow and dietary dedicated to advancing dietary purpose for the prevention and management of cardiometabolic disease. So after completing her first year postdoc fellowship at the University of Sydney, she recently joined the Georgia Institute, where she contributes to the blood pressure program. So her research passion focused on promoting plant-based and sustainable diets as key strategy for improving health outcomes. So let's welcome Dr. Tian Wang for her presentation. Thanks.
Thank you. So good afternoon, everyone. My name is Tian. I'm a dietitian and also a postdoc at the George Institute. Today, I will be talking about plant-based diet, plant-based hot-protected diet, cardiometabolic risk, and cardiovascular disease and incidence and mortality in the UK Biobank study. So just a bit of background, I'm sure everyone in the room already know that cardiovascular disease is the leading risk of death globally. And according to the WHO report in 2019, about 32% of the global death were from cardiovascular disease. And this is just the figure I took from the Heart Foundation, as Jordan already mentioned. About 1 in 4 deaths in Australia were caused by cardiovascular disease, and it's equivalent to about 1 person death in every 12 minutes. And also we can see that healthy lifestyles and diet are very important in prevention and management of this condition. And most cardiovascular disease risk factors are preventable through a healthy lifestyle by diet, exercise, or just being in a healthy weight range. And about 9 in 10 Australians, they don't eat enough vegetables. And by just eating 5 more servings of vegetables a day could reduce cardiovascular disease risk by about 17%. And in the past research, we found many evidence suggest that a healthy plant-based diet may be protective in this condition. And we already see that like many of the guidelines emphasize the importance of the intake of vegetables, whole grains, fruits, etc. However, we found many different results by this big cohort study, including EPI Oxford study, Nurses Health study, and UK Biobank study. Like some studies suggest it might be protective, but others didn't find any significant result. And if we take a like the breakdown of the diet, we can see that from animal-based to plant-based, we can actually have like different type of diet. We can have vegan, we could have ovo-lacto-vegetarian diet, which means you also have egg and dairy products, or we can have pesco-vegetarian diet, which means you could also have fish. And finally, we could have animal-based diet. And if I take a deep look down for these studies, because I'm a dietitian, I really look at how they assess the diet in the study. And I found that they only use 4 very simple questions to classify their diet into either plant-based or people who eat fish. But I think this is not enough to assess the quality of the diet. And because by only asking 4 questions, you can't get a full picture of how their diet would actually like. Like you can have a plant-based diet, but you can still eating junk food. So because of that, I also look at the current index to assess the quality of the plant-based diet. And I found that many of the index, they're using data from the full frequency questionnaire. Or the diet index can also like simply to categorize the diet into purely plant-based or animals, but they didn't taking into the current recommendations from the Heart Foundation, from the American Heart Association, or from the European Society of Cardiology for the promotion of the eating of fish and seafood. So because of that, in my study, I developed my own diet score. So I applied that diet score in the population in UK Biobank study. We include about 190,000 adults. They have a mean age about 56.3 years. About 43% of them are male. They don't have any cardiovascular disease at baseline, and they have to complete a 24-hour recall for dietary assessment. And based on, and I evaluate adherence based on the diet score that I developed on 22 food groups. And I use proportional Hadza models to evaluate the incidence and mortality of cardiovascular disease. And finally, I adjusted for like age, sex, ethnicity, deprivation index, socioeconomic status, lifestyle factors, and if they have history of cancer, hypoglycemia. And just a deep breakdown of the diet score that I designed. So I put like food groups like whole grains, fruit, non-starch vegetables, nuts and seeds, legumes, and more importantly, uncoated fish and seafood, eggs, reduced dairy products into the food groups that they receive a positive score. And I give like refined grains and cereals, meat, poultry, processed meat, coated fish and seafood, full fat dairy products, and sugar, sweetened beverage or dessert, this kind of thing into negative. So the diet score that I developed is more like a reflection of the current guidelines from American Heart Association or Heart Foundation or the recommendation from the European Society of Cardiology. And from result, we followed them for a median of 12.3 years. We identify around 20,000 instance cardiovascular disease events and about more than 1,000 cardiovascular disease deaths. And after adjusting for all these covariates, if we firstly look at the incidence, we found that so Q1 represent the individuals with the least adherence to diet score that I designed, and Q4 reflect to the individuals with the highest adherence to diet score that I designed. So for the individuals with the highest adherence, they have an 8% reduction risk in cardiovascular disease incidence. And then if we break down into different, disease category, they have about 12% reduced risk in ischemic heart disease, about 18% reduced risk in myocardial infarction and about 14% decreased risk in heart failure. And if we look at the data in mortality, we can find that for individuals with the highest adherence, they have about 28% reduced CVD mortality. They have about 32% reduced in ischemic heart disease mortality and have about 35% decrease in myocardial infarction mortality. And finally, about 49% reduction in heart failure mortality. So my conclusion is, adherence to a healthy plant-based diet rich in non-starchy vegetables, fruits, whole grains, legumes, and fish is associated with reduced cardiovascular disease incidence and mortality. And I also want to highlight we have 2 other published vegetarian diet review, one in European Heart Journal and another systematic review in JAMA Never Open if you guys want to have a look about that. And finally, I would like to acknowledge my supervisor, Professor Luigi Fontana, and Dr. Cynthia Croger, Dr. Sophie Cassidy, and Dr. Dietary. Thank you.
Thank you. For question? I have a really quick one. How did you define the CVD deaths? Like in your statistics?
So we use first from my memory, we use the registry and then we follow people up. And then we link with the UK Biobank registry for that. Yeah, but I need to look back to the method section of my manuscript to give you a more.
Just curious, like that's like a direct death caused by CVD, right? They define that as a CVD.
Yeah, it's in the. I remember it's in the registry of the record with hospital. Yeah.
Yeah.
So between Q1 and Q4, like you said, Q1 is the least adherent, and then Q4 is the most adherent. I was wondering if you looked at, I guess, socioeconomic factors and ethnicity, and whether there's any sort of correlation between the less adherent and the non-adherent, or just.
Yeah, this is a very good question. We found that people like with the highest adherence, they're more likely to be a little bit more physically active and they're more health conscious, but it's not significant. Yeah, but then from the data, it's slightly higher. Yeah.
Any other question? Yeah, please.
I just wondered, with your score, you said it was based on the 22 item. What was the score like? Was it like a simple, like 1 point if you have low fat milk and then, -1 point if you have the negative things? How exactly did the scoring system work?
Yeah, this is a very good question. So, so for each, I guess for each food groups, we were like divide them up by like 5, I think by like each 20%. So with the least adherence is like the first one, and then with the highest adherence is like the 5th one. And then we give them score range from I think -2 to 2. And then if they have the least consumption, they got like -2. If they have like positive food groups, and then like in the negative food group is like the other way. If they have the highest consumption, then it's -2. And then for the food group that they have the highest consumption, then they got like 2, or otherwise, if it's negative food group, it's minus.
It's relative, like within the cohort.
Yeah.
Who was the worst? And
yeah.
Rated against
Yeah, that's right. Yes.
There you go. Please join me. Thank you again, Dr.
Okay.
Our next speaker is Dr. Alex Tian. Alex is a lecturer in nursing at the University of Wollongong Liverpool campus, which is this building. The slides. Yeah. Okay. Yeah. Just one more. Yeah. He completed his PhD recently in March 2024. Congratulations. His research interest includes transcultural cultural nursing, primary and secondary prevention of cardiovascular disease, and care for people living in chronic disease. So,
Thank you. And thanks for the organization offering me a chance to present my final chapter of my thesis. This is the first time I present my final chapter, so I'm very happy today. Okay, so first I need to acknowledge my supervisor. One is in Melbourne at the moment, Professor Lee Kingsman, and Dr. Sally Chen is in Hong Kong. So they supervised me for about 6 years. So it was a long journey. So I'm going to talk about the perception and knowledge of using a low salt diet for preventing hypertension among the Chinese populations in Australia. It's a mixed method study, so it's a long and complex one. Give you a bit of background about the hypertension. We define the hypertension as systolic over 140 and diastolic over 90. Approximately about 34% of the Australian populations, about 8.4 million Australians were living with hypertension in 2017. Evidence show that high salt intake is a risk factor for hypertension. World Health Organization recommends to have less than 5 grams per day, which is just a bit less than 1 teaspoon of salt per day. Australian intakes, like men about 10 grams a day and women about 7.3. So by looking at the data here, the general Australian population is taking about double the recommended amount every day. Now, we need to admit that first, reducing salt intake is easy to say, but it's very hard to do it, okay? Food without salt is tasteless. We need to admit that, okay? So don't try to bring the people. They have been told, but why they don't do it? It is hard to do it. Oh, sorry. Okay, my study is about the Chinese populations. Not just only Chinese, I must admit that like all Asians, when you walk into, you have friends, okay, from Asian backgrounds, go into their kitchen, you will find that it's just like a mini medication room, okay? My partner is a white Australian. I'm not a typical like Chinese dietary, like practicing the typical Chinese diet. But in my kitchen, I still have about 15 to 20 bottles full of salt, okay, so different sauce. When we cook, sort of like a different remedy, okay, just put something in there, okay? Don't ask me the amount, okay? This is how we've been trained from the older generations and pass on me. And maybe I may also pass on to the next generations as well. So this is how the Chinese people learn how to cook. So looking at the statistic, we have approximately 1.4 million, equivalent to approximately about 5.5% of the Australian residents. They reported they are from have a Chinese background. Approximately about 32.4% of the Chinese people in China, they have salt-sensitive hypertension. So in other words, if we can actually help them to reduce the salt intake, we can actually reduce the incidence or the number of hypertension. As I mentioned about earlier, salt is actually routinely add to the food during the preparation time. In the past, there's a lot of study talk about Chinese put the salt during the cooking time, but however, the Western people, they usually have the salt from the processed food. But this sort of the thing will be changed because of the economic structure is changing. We do have a lot of processed food as well. People that move to Australia or other Western countries, they may selectively Westernize their food patterns. So that will cause another concern. Now, I need to note that in Australia, many Chinese people are not coming from the Great China regions. So it's very hard to actually get the statistic when I did the study because of the ABS only give me how many Chinese coming from China or Taiwan is quite difficult to get to, but mainly from China. But we do have people from like they are Chinese from a Chinese background from Vietnam, from Thailand. In my study, I have some people, they were actually born in the UK and in Canada. They're the second generation or the third generation over there and migrate to Australia, but they still consider themselves as Chinese. So their dietary patterns will be quite different compared to the typical Chinese from the mainland. In my research, the whole study, I have a few aims and the questions. So briefly just talk about the aims. First, I actually contacted a author in University of Peking to ask for permission to use the instrument, the tools that they use in China, which has been validated with more than 1 million people. Okay, but however, it's a very, very long questionnaire. So my I'll talk about the methodology a bit later, but I'll just keep that in mind. It's a very long questionnaire. So second, my aim is to look at the practice of the dietary practice in Chinese Australian. Look at explore their knowledge about the dietary styles, and also do they know about the effect on their health, and what factor will actually change the perception about reducing their average salt intake every day, and also identify what the facilitator and also the barriers to reduce salt. There was 4 questions in here, and it's addressed in different phases. Okay, I'm not going to repeat it here today, but if you're interested, I can leave the slide to you. Talk about the methodologies. This one is a very simple one. The whole study have 4 phase, from phase 1 to phase 4, and the underlying theoretical frameworks are used to health belief models. I want to change it to the next slide because of this diagram doesn't actually show the capacity of the study. The phase 1 is, first I need to translate the questionnaire that I used, that I got the permission from the University of Peking to change to from Chinese to English. And then the first phase get the expert panel to review. This expert panel consists of research people, their academics, nurses, and also healthcare consumer. And then after that, I adjust the questionnaires and then go to the second part of the study, which is the psychometric testing. This part is the key part of my study. I spent about 6 years to complete my PhD program. And this part is about my first 3 years work. It's a very long process and pretty scary because it's time consuming. FDA approval is another major problem. It took me about 7 months to get through. Yeah, so that is something that when I look at that this week, when I prepare for this presentation, I found this will be not something that I will do it again because it's very scary. When you do a PhD by publications, time is not on my side. Okay, so after I got the questionnaires, I know that there are some questions can be taken out, but however, because of the COVID, there's not much time for me left because of 3 years already up. I only have 3 more years. Okay. So then I go to phase 2, which is actually the quantitative survey, which is actually I use the validate questionnaire to do the survey. Then I do the telephone interview, supposed to be a focus groups, but because of the COVID, need to change it to interviews. So the key finding is like they have inadequate salt knowledge, mainly about the negative impact, how they affect the health behavior change. What I find is the people with high blood pressure and normal pressure, they have no significant difference between these 2 groups in terms of they perceive the benefit of reduced salt intake. Come from the qualitative review interview, they say that like high blood pressure is not serious enough to cause death. 84% of the people, they have never received any medical advice by anyone to reduce their salt. And one of the participants say that the local GP mainly focusing on secondary prevention. There's a knowledge gap in here. The insufficient internal and external pump to trigger the cause of actually is a problem. Because of what I found is the participant actually received the salt reduction advice by their doctor. They actually they consume more salt than those people they don't receive any advice. Stronger the taste, they actually perceive like more high health threats. The problem with that is like, it does not translate the knowledge, they know that, but it doesn't actually put into action. So some people actually told me like, they're happy to change if they have any cultural relevant support, which including the recipes or any alternatives. So when they go to the kitchen, they know that they can't put this, but they have some substitutes. I just briefly talk about that because of this one, I can't actually have enough data to show the health belief model is not good enough. It's not accurate enough to predict the Chinese health behavior. But that is what my finding in my like 180 samples. the sample size 188, to show that there's actually some of the contact can actually be put on to replace. Today, I don't draw conclusions because there's a lot of open area that can be do, but I actually want to say, from what I have found in here, the key thing is there's something is missing from this study. Why they actually not translating the knowledge to practice? They know this is a problem, but why is actually not changing their behavior? So that's why when I first started the presentation today, reduce cell intake is easy to say, but hard to do it.
Thank you. Thank you. Very interesting. Time for question. Yeah, please.
Nurses are known for sitting in tea rooms and making comments about patients. You know, so someone who's had a second infarct, for example, and still smoking, they're out on the fire escape, and you think things like, oh, you think they know, like that type, quite judgmental. But behaviour change is really hard, and sustaining behaviour change as well is even harder. I think with this study, the things that, and you learn this, I guess, with the counselling sort of literature, motivational interviewing, is unless something is important enough and unless people are confident, they just don't attempt it. Yeah, so knowledge it's not about knowledge. I mean, I would say that probably every person who smokes knows they shouldn't smoke, but it doesn't stop them smoking. Okay, and I just opened a box of chocolates someone gave me before I walked into this room. I had 2 Freddo frogs. I was actually going to bring them, but I'm really glad that all the dietitians are here. I know I should not have had those 2 Freddo frogs. Yeah, so I get there is something missing. I totally
Something is
get
missing,
that.
yeah. But my study, the limitation because of like it doesn't extend to that part. I haven't got that type of questions in the full interviews to collect the data about why they don't want to change. Yeah, so that could be my future studies.
I think some of it was in some of the quotes you had indicated to me that people didn't see it as important.
Okay, so probably in the interest of time, we have to move on. Thanks again,
Yeah,
Alex.
no problem.
Thank you. Let me introduce our last speaker, Katherine Riley. She's a nurse, academic, and lecturer in the School of Nursing at the University of Wollongong. She has recently submitted her PhD thesis. Congratulations. She used an ethnographic, am I pronounced right?
Yes.
Methodology to explore the, oh my God, rescue citation experience and the practice of rural nurses. Speech is yours. Thank you.
Thanks, Peter. So yeah, my name's Kat. I'm a registered nurse and I do work at the University of Wollongong in the School of Nursing, but in a previous life, I used to work at Liverpool ICU and then I moved down to the South Coast and started working at a small rural ED department. And I guess the catalyst for me doing this PhD was probably the extremes of these two ends of ICU and moving to a small rural ED. And so today I wanted to talk to you about my PhD in a couple of minutes and look at the insights and some ethical reflections. My supervisors are Associate Professor Beck Middleton, Val Wilson and Luke Malloy. Oops. Just to give you a bit of context, the diagram on the right-hand side shows, I guess, from the Australian Institute of Health and Welfare, small and medium rural towns have significant sort of maldistribution of nurses. And this is also the same with medical officers, physios, dietitians. And so some of the challenges that rural nurses face is that they work with extended roles, but also with limited staffing. My study used ethnography, which is a qualitative study that looks at culture, and I wanted to look at the experiences of rural nurses in resuscitations because I've been in resuscitations in these small ED departments. And when you have an on-call doctor and it's a GP that's coming from home, you have point of care testing, limited radiology and some telehealth services. you throw in a resuscitation and it really becomes quite a stressful situation. But I guess from an ethical point of view, I just really wanted to talk about, so this is the title of my study, about getting Human Research Ethics Committee approval. It was a 10-month, so beat you, Alex, process. When you put in the words observing resuscitations, the ethics committee wants a little bit more, they want to look at the risk and benefits. And so for me, I wanted to use data from the nurses, but because I was going to be observing resuscitations, the privacy to patients was considered a very high risk. So normally what I did try to do was do a waiver of consent, but that was denied because it was recognised that the public benefit wasn't, I guess, weighed, when you're looking at risk and benefit, it wasn't as beneficial compared to the risk of privacy. So what did I do? So what we ended up having to do was that consent was meant to be for patients prior to their deterioration, and also all for the family members. But if you can try and imagine that when a patient presents or asking a family member to consent, it's always really tricky. So I think looking at it in retrospectively, I would have preferred to have done maybe a co-design or some sort of collaboration with rural areas, rural communities, just to try and have some input into whether this would be beneficial for their rural community. So my mouth is so dry. I think I've eaten a teaspoon of salt. So my findings, I had 2 papers from my findings. First one was around informal leadership, around their roles. When doctors aren't on site, nurses are running resuscitations, but there's this, they don't have leadership training. So, and this showed a real definite, I guess this is a look at my strategies as my recommendations towards the end, but shared leadership was sort of present in some resuscitations, and this looked like nurses supporting or advocating for patients, or but they often stepped back when a doctor was on site as opposed to leading a resuscitation. Multiple roles was another thing. If you can imagine in resuscitation with no doctors, no social worker, no x-ray, nurses are taking on multiple roles, and this results in cognitive overload. So, and in a resuscitation, that's not a good idea. My other finding looked at the bookends of resuscitation. Preparedness is really important. Nurses need to, their sense of preparedness was challenged because in rural settings, we don't have resuscitations every day. And so gaining experience is really challenging. And also going to training and education when the context doesn't match their environment really means that they're not getting the contextual training that is needed for resuscitation. And lack of warning. Health literacy was an issue in rural settings, and patients often turned up in a deteriorated state, and so that affected nurses' resuscitation preparedness. And post-resuscitation, in a rural setting where you don't have doctors on site or additional staff to come and support nurses were then having to go back to their patients, not being able to make sense, no debriefing, all those sort of things. So what am I going to do now? So these 5 areas are probably areas that I'd like to look at further. Happy to talk to you later on this afternoon about these a bit more, but I guess one of the key things is that trying to offload cognitive load is a really important part in rural resuscitations, and looking at professional isolation and trying to mitigate some of those challenges through these types of strategies moving forward. So thank you, everyone.
Thanks, Katherine. Time for a question. Yes. Yeah.
Thank you so much, Katherine. That's a great PhD and really highlighted the challenges like in rural settings.
Yeah.
So you mentioned sharing the cognitive load. Do you think, maybe, I know the medical officers aren't always present, but when they are, can they actually help with the education and help with the sort of briefing the nurses on the resuscitation in terms of that preparedness, do you think? Like getting them co-designing a program or?
Yeah, I mean, I guess it's tricky because a lot of the rural areas that we're talking about in these small rural EDs usually have GPs that are working in their GP rooms. So doctors, they've got their full-time role. They come over in a resuscitation or to see patients. And so I guess collaboration is a little bit trickier. But I think in regards to preparedness and training, I think it needs to be definitely co-designed. I think we need to be putting a fit for purpose into each area, not doing something that's like like, because a lot of the nurses that I talked to, they were going to different training centres, and they were resuscitating people with, in simulation with like 3 nurses and 3 doctors and, a social worker and all those sort of things. And it's not contextual. So they come back and they think, well, I still don't know how to lead a resuscitation or that sort of thing. So I think definitely there's, but we need a lot more input and a lot more resources to be able to do that. Yeah. Thank you.
Cool. Thank you.
Thanks.
Please join me to thank Katherine and all the speakers. So to wrap up, I think, do we have another slides? Oh, yeah. So please, feedback is always very important. If you can just scan the QR code. And I really want to thank Sabine, Haley, and Alex for your help to book the room and make this happen. And I also want to thank Alison and Marie to make this happen and providing the food and drinks. And everyone, please enjoy the networking things. And thanks again for the happy Friday.